Thank you for the invitation. I am going to present the data on behalf of Executive Committee of the DAPA-HF study, and I am going to summarize the most recent findings on the benefit of dapagliflozin first and repeat events in patients with heart failure and reduced ejection fraction in the DAPA-HF. These are our disclosures. Let me start by saying that briefly summarize the DAPA-HF trial. As you all know, that in DAPA-HF trial we demonstrated that among patients with heart failure and reduced ejection fraction, SGLT2 inhibitor dapagliflozin significantly reduced the risk of cardiovascular death or worsening heart failure. And in this trial, we defined worsening heart failure event as a hospitalization for heart failure or an urgent outpatient visit, which required IV therapy. However, we are all aware that patients with heart failure, they will very often experience so-called repeated hospital admissions during the natural course. And in this study, in the DAPA-HF analysis, primary analysis, we used time to first event method. And as we are all aware, this conventional time to first event analysis very often ignores this issue of so-called heart failure burden, which obviously is mainly around repeated hospital admissions. And we also know that this time to first event analysis is not ideal, even in the case once we take composite of cardiovascular death and heart failure hospitalization, particularly in the context when death occurs after first hospital admission. Additionally, I believe that we are now in heart failure studies discussing how shall we analyze this heart failure burden, and there are several ideas, and this time to first event, all this analysis, they have been sort of criticized, as we all know, particularly in the context of some cases they may overestimate treatment, as the treatment may wane over time, and there may be some subgroup of patients who may not respond well to the therapy with several recurrent events, clustering kind of effect, and these patients may be of particular importance once we target this group of very high risk group patients. So this is why we decided and we specified secondary analysis in DAPA-HF, and I will show in a second the data. In this secondary analysis, we analyzed all heart failure hospitalizations, both first and repeat. The trial design, in summary: key inclusion criteria, symptomatic heart failure with reduced ejection fraction, and I am very glad that one of the panelists mentioned have MREF. I had the privilege to chair the guideline committee in 2016 when we introduced this MREF classification. However, in this study, we focused on patients with heart failure and reduced ejection fraction, defining reduced ejection fraction as EF of 40% or less. And I am very glad that discussion about natriuretic peptides preceded my presentation in this study, NT-proBNP of 600 plus for those who were hospitalized within the last 12 months, 400, or in AF or flatter with 900 as a cut levels. The key inclusion criteria comprise lower eGFR, symptomatic hypertension, and type 1 diabetes. And again, for your perusal, just to remind you that the primary endpoint was met. We very clearly demonstrated that the risk of cardiovascular death or worsening heart failure was significantly reduced with hazard ratio of 0.74. This is the design of the study. During the screening period lasting 14 days after achieving informed consent, checking inclusion, exclusion criteria, clinical assessment, and all these studies, we randomized our patients into those receiving optimal medical therapy and placebo or optimal therapy with dapagliflozin using 10 milligrams once daily dose. As you know, the study was designed as an event-driven study, and we calculated that 844 primary outcome events would give us enough power to verify our hypothesis. The visits are scheduled, the follow-up visits was scheduled at day 14, 60, 120, and then every other 4 months. For the recurrent events analysis, and this is crucial because this is extremely complex, also from the statistical point of view, we use different methods. We use the method called Lin-Wei-Yang-Yin method, and another pre-specified method we use, and this is quite often used in this kind of analysis. We use joint frailty model, which somehow takes into consideration the semi-competent risk of cardiovascular death. And as you know well, this method kind of takes into consideration that those with higher frailty are around those who are having multiple hospital admissions. So we use different methods generally accepted for the recurrent event analysis, which, as we all know, is not that easy. This is the summary of the components of the primary endpoint here using time to first event. The first heart failure hospitalization risk was, as you see here, reduced by 30%. And the curve separated very early, and the effect sustained until the end of the follow-up. Here comes the recurrent heart failure hospitalization analysis. I just want to draw your attention that among 4,744 patients, more than around 12%, despite relatively short period of time, experienced at least one hospital admission. But as you see, 380 patients experienced one hospital admission, whereas the total number of hospital admissions was much higher, with and here, as you see, with 809 total number of first and recurrent hospital admissions. Here you see the key baseline characteristics according to heart failure hospitalization during the follow-up. As I said, around 12% of patients experienced at least one admission, 4% admitted at least 2 admissions, and the summary is very clear. Those with multiple admissions, they tended to have more advanced heart failure with more comorbidities, as you see in this slide, with more atrial fibrillation, hypertension, more impaired or more often impaired kidney function. Here is severity of the disease, also demonstrating that those with hospital admissions, they tended to be sicker and also had elevated NT-proBNP. Here is the treatment demonstrating more or less the same pattern. Those with heart failure hospital admissions, they tended to be sicker, and this is reflected here. Here we have a summary of the number of patients with one or more hospital admissions, and this is fairly interesting data showing very clearly that dapagliflozin tended to reduce not only first hospital admission, but also tended to significantly reduce risk of recurrent heart failure hospitalization. Additional finding, which I would like to focus your attention here, is that once we focus only on first or time to first hospital admission, we will miss at least 32% of all hospitalization in our analysis, which again explains why we would not properly evaluate heart failure burden in the clinical trials. Here are analysis summarizing and comparing time to first event versus recurrent events analysis of cardiovascular death and heart failure hospitalization. And as you clearly see, I don't know whether you see the arrow here. As you see in this time to first event simple Cox model, the hazard ratio was reduced by 25%. In the recurrent events analysis, rate ratios were similarly, if not even more, reduced. Particularly if you go for this joint frailty method with heart failure hospitalization, the risk reduced by 29%. Here again is a second part of this analysis with the data summarizing absolute risk reduction and number needed to treat analysis. And as you clearly see, if we take time to first event analysis, both absolute risk reduction and number needed to treat are much higher or less favorable, make it this way maybe, than if we take recurrent events analysis. So in other words, recurrent event analysis gives us the real picture of heart failure burden, both CV death or heart failure hospitalization, and heart failure hospitalization in the context of absolute risk reduction, and particularly in the context of number needed to treat, are much more favorable, favoring dapagliflozin once we use this recurrent events analysis. So if I may conclude in summary, even over a relatively short period of follow-up, just to remind you that the median follow-up of only 18 months, a large number of patients experience recurrent heart failure hospitalization. So 32% of all heart failure hospitalizations were either second or subsequent events, which is really important because, as I mentioned, having this time to first analysis, we would miss this 1/3 of these events. Patients who had multiple heart failure hospitalizations, they had more advanced disease and with more comorbidities. Dapagliflozin significantly reduced both the risk of first and recurrent heart failure hospitalization, and the relative and absolute reductions were really large. And finally, I would like to say that the reduction in risk of recurrent heart failure hospitalization with dapagliflozin was even more pronounced after accounting for the semi-competing risk of CV death in this frailty model. So thank you for your attention. I'm very happy to take questions.
Thank you, Dr. Bonikowski, for that excellent presentation. Minna Walsh from Indianapolis will lead the discussion.
So congratulations on extending the findings in DAPA-HF. As you're well aware, this trial has certainly interested the heart failure community with the outstanding results. I have, and I do think the number of heart failure hospitalizations and recurrent hospitalizations is a very patient-centric endpoint to focus on. I do have one question for you, which is that one of the, you did mention, of course, atrial fibrillation, chronic renal insufficiency, and hypertension and diabetes as the comorbid disease factors that drive hospitalization. Another one is respiratory disease and COPD, and I wondered if you and the other investigators had analyzed that data as an endpoint as well.
Well, sorry, I don't know whether you can hear me. Can you? This is a subject for another analysis. In this particular group, we have not analyzed the effect. And for the paper, I fully agree, and we prepared this analysis. We want to use the model to predict first and repeated hospitalization using all clinical baseline characteristics. So it may well be, as you are saying, that there are certain independent factors, not only in this just a simple comparison, but in this multivariable analysis, which would tell us which of this clinical data or background would predict independently of each other the risk of repeated hospitalization. Point is very well taken.
Right. Thank you. Lee, do you have any questions? Lee, I think you're on mute.
Yeah, no, so no additional questions. One comment I did want to make is that I did think it was reassuring that our large registries had predictors of readmission, and this trial also showed that. So I do think that we're validating some of the risk factors, and does that define target areas for us in terms of identifying or looking at future trials? And I agree that looking at the full burden of heart failure is really critical here. We may delay the first admission by 6 or 8 or 10 weeks, and that might be statistically significant in a large trial. But if there's still 5 heart failure admissions in a year, from the patient's perspective, it might not be very different. So I do like this analysis, and I think this defines something that we probably should do in other clinical trials going forward.
Lee, from a practical standpoint for our listeners, are you beginning to prescribe diabetic medications now for your cardiac patients, or are you still deferring that to the primary care physicians and the endocrinologists?
We've just started to prescribe some of these medications, but it is complicated because some of these patients are on multiple diabetic meds, and the questions oftentimes come up: which of the medications should we be stopping or adjusting in order to get this on board? I think where it may be more straightforward for us is in the non-diabetic population, which originally was not where we were focused on. I think as heart failure docs, that may be an area where we may feel more comfortable adding this as yet another class of drugs. In the diabetics, I think forming partnerships with our primary care docs and our endocrinologists, which is the approach my practice has taken, is really helping us. And I must say, we are learning a lot more about diabetes management than we had in the past. And part of it is that we've just been thrust into this field. But we do need our experts, our colleagues, to kind of guide us, especially on some of these more complicated diabetics that are on multiple meds.
Terrific discussion. Thank you very much.